Thank you guys for joining us for this afternoon's PGY2 webinar on osteoporosis. We're incredibly fortunate to have an SIUE alumnus presenting today, Dr. Dana Leefers. She's currently a PGY2 ambulatory care resident with HSHS Medical Group in Highland, Illinois. So thank you so much, Dr. Leefers, and I'll turn it over.
All right, thank you, Chris, for the introduction. So today we are going to be talking about osteoporosis, and we're really going to be focusing on the postmenopausal women. So, trying to get my slides to advance here. There we go. So osteoporosis is the most common bone disease affecting approximately 10.2 million Americans, and more than 2 million osteoporosis-related fractures occur annually in the United States, and more than 70% of these occur in women. It is characterized by low bone mass, deterioration of bone tissue, disruption of bone architecture, compromised bone strength, and an increase in the risk of fracture. Osteoporosis is preventable and treatable, but because there are no warning signs prior to a fracture, many people are not being diagnosed in time to receive effective therapy during the early phase of the disease. But even after the first fracture has occurred, there are effective treatments to decrease the risk of future fractures. About 1 out of every 2 Caucasian women will experience an osteoporosis-related fracture at some point in her lifetime, as will approximately 1 in 5 men. The most common fractures are those of the vertebrae or spine, the proximal femur or hip, and the distal forearm or the wrist. Specifically, hip fractures are associated with an 8 to 36% excess mortality within 1 year and are followed by a 2.5-fold increased risk of future fractures. Approximately 20% of hip fracture patients require long-term nursing home care, and only 40% fully regain their pre-fracture level of independence. Despite availability of cost-effective and well-tolerated treatments to reduce fracture risk, only 23% of women aged 67 or older who have an osteoporosis-related fracture receive either testing or a prescription for a drug to treat osteoporosis in the 6 months after that fracture. So pretty astonishing statistics. There's multiple guidelines on how to treat osteoporosis. There's the ACOG guidelines, but really the ones we're going to be focused on today is the 2014 National Osteoporosis Foundation and the 2016 AACE ACE guidelines on postmenopausal osteoporosis. And those actually were just published a couple months ago. I do want to point out, though, that there are other guidelines specific for men with osteoporosis and for glucocorticoid induced osteoporosis. So just kind of going through the risk factors for osteoporosis, there's a lot. So it breaks it down by lifestyle factors such as alcohol abuse is a big one, along with smoking smoking, either active or passive. And then your genetic disorders such as cystic fibrosis, and then especially the parental history of hip fracture. You also have your various disease states such as your Cushing syndromes, diabetes, both type 1 and 2, celiac disease, gastric bypass, your inflammatory bowel disease, and even sickle cell disease and your autoimmune diseases can increase the risk of having osteoporosis. There's also epilepsy, multiple sclerosis, Parkinson's disease, and then other miscellaneous diseases like COPD, depression, end-stage renal disease. So pretty much anything that you can think of probably is going to affect the osteoporosis risk. And then specifically as pharmacists, we want to focus on the medication risk factors. And so you have your anticonvulsants along with your anticoagulants. But really it's going to be the steroids, greater than 5 milligrams per day of prednisone equivalent for greater than 3 months. And then also your PPIs and your SSRIs and your thyroid hormones in excess can really increase the risk of osteoporosis. We can't forget about the environmental risk factors, and the most important of these are the personal history of falling, muscle weakness and gait, balance, and visual defects. And then dehydration is also a risk factor for falling. So all postmenopausal women above the age of 50 years should undergo clinical assessment for osteoporosis and fracture risk. There's multiple ways to assess someone, and it kind of is a stepwise process. So first thing is you want to do laboratory testing to exclude any secondary causes of osteoporosis that we just talked about. You also want to look at the bone mineral density, or the BMD, bone turnover markers, and then the WHO Clinical Fracture Risk Assessment, or the FRAX score. And we'll talk about each of these individually. So bone mineral density testing should be completed using an axial dual energy X-ray absorption machine using the spine and hip. It's also called a DEXA. And BMD is expressed with either a T-score or a Z-score. T-scores are used for diagnostic classification in postmenopausal women, and the T-score is expressed as a standard deviation and has been shown to correlate with bone strength. So it's an excellent predictor of future fracture risk. And in fact, for every standard deviation below the mean, fracture risk increases by twofold. Now your Z-scores, those are recommended for premenopausal women with a Z-score -2 or lower, defined as below the expected range for age, and greater than -2 as within the expected range for that age. So BMD testing is the gold standard in diagnosing osteoporosis, and results are used to establish or confirm a diagnosis, predict future fracture risk, and also monitoring your patients. So patients with a T-score at -1 or above are classified as normal. And then if the T-score is between -1 and -2.5, that is considered to be osteopenia. And then a T-score below -2.5 is classified as osteoporosis. If the patient has osteoporosis with fractures, it is considered to be severe. So your indications for testing includes adults with a chronic condition taking a medication associated with low bone mass or bone loss that we previously had talked about. And then specifically for your men, anyone age 70 years and older. And then if your men are between the ages of 50 and 69 years of age with previous fractures or risk for fractures, such as delayed puberty, hyperthyroidism, or even COPD. And then all women greater than the age of 65 years old should get a BMD test. And then all postmenopausal women with a history of fracture without major trauma, osteopenia, or starting or taking long-term systemic glucocorticoid therapy should get tested. And then other peri or postmenopausal women with risk factors for osteoporosis, they can undergo testing if they're going to be willing to consider pharmacological interventions. And some of those risk factors include the low body weight, again, the long-term therapy, the family history of osteoporotic fractures, early menopause, current smoking, and excessive alcohol consumption. So your BTMs, those are going to help provide a dynamic assessment of skeletal activity. Although they cannot be used to diagnose osteoporosis, elevated levels can predict more rapid rates of bone loss and are associated with increased fracture risk independent of BMD. These markers respond quickly to therapeutic intervention, and changes in markers have been associated with bone response to therapy and fracture risk reduction. So decreases in your BTMs compared to pre-treatment levels with therapy can range from 30 to 50%. And the main markers that we look at is SCTX, and that's associated with high bone turnover, and higher levels could represent malabsorption or poor compliance and the need for evaluation for causes of secondary osteoporosis. And then the preferred formation marker is your PINP. It must be noted, however, that a recent fracture will transiently raise your BTM, so just be aware of that. And then there's also your vertebral imaging. Vertebral fracture is the most common osteoporotic fracture and indicates a high risk for future fractures, even when the T-scores does not meet the threshold for osteoporosis. Most vertebral fractures are asymptomatic when they first occur and are often undiagnosed for many years. So proactive vertebral imaging is the only way to diagnose these fractures. So if the T-score is less than -1 and the following is present, which is a woman aged greater than 70 or a man aged greater than 80, if they have a historical height loss, and if they have a self-reported undocumented prior vertebral fracture, and again, that glucocorticoid therapy, then they are indicated for the vertebral imaging. The FRAX is a useful tool that calculates the 10-year probability of hip or major fractures. It isn't intended for post-menopausal women that are on drug therapy. So it's only for people that are not on drug therapy. It can be calculated with either the femoral neck BMD or total hip BMD, but when available, femoral neck BMD is preferred. So a few examples of the risk factors included in the FRAX include current age, gender, prior fractures, BMI, smoking, and alcohol. There are online tools to calculate the FRAX, but it's important to keep in mind that it's not going to be 100% accurate. So it's going to underestimate future fracture risk as it reports only risk for hip and major fractures. And then it's going to underestimate the risk in patients with multiple osteoporosis-related fractures. And whenever the lumbar spine BMD is much lower than the femoral neck BMD. And it's also going to underestimate the risk in those with secondary osteoporosis and those at an increased risk of falling. So we talked about all the different ways to diagnose and assess a patient for osteoporosis, but who really gets treatment? And the guidelines indicate that if there's osteopenia or low bone mass and a history of a fracture of the hip or spine, they should be assessed for treatment. And then if the T-score is -2.5 or lower, they should be considered. And then if the T-score is between -1 and 2.5, which is that osteopenia range, that's whenever you really look at the FRAX. And if the FRAX is greater than 20%, or the 10-year probability of a hip fracture is greater than 3%, then you'll want to consider treatment. And note that this FRAX is sensitive based on the country. So those cutoffs are specifically for the United States. If you were in a different country, there would be different cutoffs that you would look at. Oh, and I just realized I'm behind on my slide. So there you go. Okay, so all patients should be encouraged to participate in regular weight-bearing exercise and tobacco cessation to help build bone strength and limit bone loss. And additionally, fall prevention management strategies should be identified to help prevent potential fractures. You can consider the use of hip protectors in individuals with high risk of falling. Now, patients should limit their caffeine intake to less than 1 to 2 servings per day. And kind of the reason behind this is interesting. Caffeine intake can lead to a slight decrease in your calcium absorption and an increase in calcium excretion. But really, the most important effect of caffeinated beverages is that by replacing milk in the diet, they contribute to overall inadequate calcium intake in the United States. Excessive intake of alcohol should also be avoided, as it leads to a predisposition to falling, calcium deficiency, and chronic liver disease. And then chronic liver disease, in turn, predisposes someone to vitamin D deficiency. So providers should measure vitamin D levels in patients who are at risk for vitamin D insufficiency, including those with osteoporosis. And really, the levels should be maintained between 30 and 50. Many patients with osteoporosis will need more than the general recommendation of 800 to 1,000 international units per day. And the safe upper limit for vitamin D intake for the general population is around 4,000 international units. So along with vitamin D, patients should be advised on a diet that includes adequate amounts of calcium intake. So for men 50 to 70 years of age, that's 1,000 milligrams per day. Greater than 71 for men, it's 1,200. And then women, all of women greater than 50 years of age, it's recommended the 1,200 milligrams per day. This is a nice way to estimate calcium intake. On average, the daily calcium intake among Americans is about half of what is recommended. So this is a good way to determine what their total intake is and to determine if supplements are needed. So there is a big debate about calcium supplements. Some studies have shown that calcium supplements can increase the risk of cardiovascular disease. So I kind of want to dive in deeper into this topic because there was a recent meta-analysis published just a month or two ago that really looked at the safety of calcium supplements. So again, this was a meta-analysis, and it looked at different studies. There's 4 randomized control trials, there's 1 case control, and there's 26 cohort studies. And the way this meta-analysis was set up is it broke down the results by the studies. So first I want to talk about the results of the RCT studies. So there are 2 trials that analyze the effect of calcium and vitamin D. The Women's Initiative trial had roughly 36,000 post-menopausal women aged 50 to 79, and they either received 1,000 milligrams of calcium plus 400 units of vitamin D daily or placebo. And throughout this WHI trial, 6 reports examined CVD outcomes at the end of 7 years, and then 1 report included CVD outcomes at 5 and 12 years of intervention. Now, the Record trial examined the effects of 3 years of daily supplementation with 1,000 milligrams of calcium and 800 units of vitamin D3, or both, on CVD deaths and cerebrovascular disease death among 5,000 patients. Now, 85% of this population was female and older than 70 years, and this population was recruited from fracture clinics or orthopedic wards in England and Scotland. But both of these trials saw no difference in CVD or mortality when compared calcium supplements versus placebo. So then they looked at 3 trials, again, RCT trials, that looked at the effects of supplementation with calcium alone, and they didn't incorporate vitamin D into this. The average calcium intake did range from 1,000 to 1,200 milligrams. So the calcium intake fracture outcome study, or the CAIFOS, was from Western Australia, and it looked at 1,200 milligrams of calcium carbonate daily for 5 years on the ASCVD risk in about 1,400 elderly women, which was older than 70 years, and they were recruited from the general population. And then the Auckland calcium study, again, had about 1,400 postmenopausal women. These women were older than 55, and they received 5 years of daily supplementation with calcium citrate 1,000 milligrams or placebo. And this trial examined the outcomes of myocardial infarction and stroke after 5 years. And then the record trial, which I described earlier, it also reported the effects of calcium supplementation alone on cardiovascular deaths. So none of these studies found a statistically significant effect of calcium supplementation on CVD outcomes. So far, the meta-analysis is doing pretty good, showing that calcium typically doesn't cause any harm. But then this is where it kind of gets a little fuzzy, as they start to look at the case and cohort trials. So on the population ranged from ages 17 to 99, sample sizes ranged from about 800 to 300,000, and the follow-up ranged from 8 to 30 years. The calcium in these trials was assessed by food intake questionnaires and ranged from 400 to 2,400 milligrams per day, but few beyond 1,600 milligrams. So this chart shows the associations between total foods and supplements, which is on the top, dietary foods only, which is in the middle, and supplemental calcium intake levels on the bottom, and the risk for CVD, cardiac, or ischemic heart disease mortality. Basically, what this chart shows us is that there is no consistent dose-response relationship seen between calcium intake levels and risk for CVD, cardiac, or ischemic heart disease mortality. So then they break it down a little bit more, and this chart shows data of 12 studies that were reanalyzed to estimate the risk for CVD mortality. And this chart compared calcium levels above 1,000 milligrams with those below 1,000 milligrams per day. Although most results did not reach statistical significance, one study did show that dietary calcium intake levels greater than 1,000 milligrams were associated with a higher risk for CVD mortality. Reported mean calcium intake specifically for this trial was about 1,200 milligrams. And specifically, the increased CVD mortality in men was observed at calcium intakes greater than 1,500 milligrams. And then another study showed that supplemental calcium intake was associated with an increased risk in CVD mortality in men, but a decreased risk in women. And yet another study found lower risk for CVD events or mortality among women who took more than 1,000 milligrams compared to those who did not take calcium supplements. So basically, these studies showed inconsistent results as well. So this figure shows associations between dietary or total calcium intake levels and the risk for total stroke, which is on top, and stroke mortality, which is on bottom. The dose-response relationships between calcium intake levels and risk for total stroke or stroke mortality were highly inconsistent, with some studies showing opposite trends for total stroke risk, and it couldn't be explained by the sex of the study populations. So far, we're not doing a very good job with these cohort studies. It's showing really inconsistent results. So the authors then tried again to reanalyze 10 studies to estimate the risk for stroke mortality or total stroke, comparing calcium intake levels with those below 1,000 milligrams. And 2 studies showed that dietary calcium intake was associated with an increased risk in total stroke for men and women. But again, all the other studies did not show that effect. So the authors did conclude that calcium intake from either food or supplement sources at levels within the recommended tolerable upper intake range, which is 2,000 to 2,500 milligrams, was not associated with CVD risk in generally healthy adults. Although a few of those cohort studies reported increased risk with higher calcium intake, risk estimates in most of those studies were small, plus or minus 10%, and wasn't considered clinically important, even if they were statistically significant. So the National Osteoporosis Foundation and the American Society for Preventative Cardiology just posted an update on their calcium guidelines. And based on moderate quality evidence, level B, calcium and vitamin D from food or supplements has no relationship, beneficial or harmful, for CVD or mortality in your generally healthy adults. So calcium intake that doesn't exceed that 2,000 to 2,500 milligrams per day should be considered safe from a cardiovascular standpoint. Now, they do state that obtaining calcium from food sources is preferred, but supplemental calcium can be used safely to correct any shortfalls. Now, just to make it more confusing, there actually is conflicting data on whether calcium and vitamin D even help with the reduction of risk factors. In fact, the USPSTF states that low doses of calcium are ineffective, and there is insufficient data existed to recommend higher doses to prevent osteoporotic fractures. But unfortunately, I don't have time to get into all of that data today, as I want to go into the pharmacological agents. So just know for now that the NOF does recommend calcium intake to help prevent osteoporotic fractures. So the pharmacological agents are your bisphosphonates, which are probably the ones you're most familiar with, calcitonin, estrogens, your PTH, and your rank L inhibitors. So bisphosphonates, they are going to work at the sites of active bone remodeling and reduce the activity of bone reabsorbing osteoclasts. All bisphosphonates can affect renal function and are contraindicated in patients with estimated GFR below 30, with zoledronic acid being contraindicated in less than 35 mils per minute. They're also contraindicated with hypocalcemia, active upper GI disease, or malabsorption, and then if you have any esophageal abnormalities. Side effects are similar for all of the bisphosphonate medications, including GI problems such as difficulty swallowing and inflammation of the esophagus and stomach. Note that decreases in calcium concentrations and phosphorus concentrations can be seen in the first month. So there have been rare reports of osteonecrosis of the jaw, or ONJ, with long-term use of bisphosphonates for osteoporosis, though ONJ is much more common following high-dose IV bisphosphonate treatments, mainly for patients with cancer. And the risk for ONJ appears to increase with duration of treatment, typically beyond 5 years, or in patients with acute renal impairment. Some of the risk factors for developing ONJ include your dental conditions, invasive dental procedures, or poor dental hygiene. And then, although rare, low trauma atypical femur fractures may be associated with the long-term use of bisphosphonates, again, greater than 5 years of use. Pain in the thigh or groin area, which can often be bilateral, precedes these unusual fractures and serve as a red flag, and this would require discontinuation of therapy. And then your IV ibandronate and zoledronic acid can lead to acute phase reactions like fever and muscle aches. And then there is a possible increased risk of AFib, but not of stroke or cardiovascular mortality. So under ideal conditions, the absorption of orally administered bisphosphonates is less than 1%. So it is imperative to properly educate your patients on how to take bisphosphonates. I have the specifics for each medication on the slide, but in general, one should drink water or take it with water to minimize the chance that the tablet will stick in the esophagus, and typically they should remain upright between 30 and 60 minutes. So I really like this chart because it breaks down the different efficacies of the bisphosphonates. So alendronate reduces the incidence of spine and hip fractures by about 50% over 3 years in patients with a prior vertebral fracture or in patients who have osteoporosis at the hip site. And then it reduces the incidence of vertebral fractures by 48% over 3 years, and then non-vertebral fractures by 30%. Notice ibandronate only reduces vertebral fractures. It has not been shown to reduce hip or non-vertebral fractures. And then you can see the other percents on the slide, but zoledronic acid has a really good data for vertebral fractures at 70%. And it also does have the non-vertebral and hip fracture data as well with it. So estrogen can lead to prevention of osteoporosis, can cause relief of those vasomotor symptoms, and it's been shown to reduce your vertebral and hip fractures by 34% and your non-vertebral fractures by 23%. There is quite a few adverse drug reactions with the estrogen. It can increase the risk of fluid intention, abdominal pain, and headache. And there's a 3-fold increased risk of VTE in patients that use estrogen. It's contraindicated in pregnancy, breast cancer, and then, of course, any thromboembolic disease. Estrogen was actually once considered the treatment of choice, but therapy really should only be considered for women at significant risk for osteoporosis and for whom non-estrogen medications are not considered to be appropriate. So we'll talk about what's first line recommended, but typically estrogen is one of our last line medication options. There's also raloxifene. It is a selective estrogen receptor modulator. So it acts like an estrogen agonist in the bone to prevent bone loss. And it has an estrogen antagonist to block some estrogen effects in the breast and uterine tissues. So ultimately, it's going to decrease bone resorption, increases bone mineral density, and decreases fracture incidence. It can reduce your vertebral fractures by 30 to 50%, but has not been shown to reduce hip fractures. It does have one benefit, that it's been shown to reduce the risk of breast cancer. It's contraindicated in women of childbearing potential and previous VTEs. Your adverse drug reactions include your DVTs, hot flashes, leg cramps. It can reduce your total cholesterol and LDL, and it does interact with your bile acid resins, warfarin, and thyroid hormones as expected. There's also another product out there, and it's a selective estrogen receptor modulator plus estrogen, and it shows that it can increase the hip BMD by about 2%, and it can increase the lumbar spine BMD by about 1.5%. And then your ADRs and contraindications are going to be similar. So because of a suggested analgesic effect, short-term prescriptions of calcitonin are often given to patients with acute painful vertebral fractures with hopes of an analgesic effect. It can reduce fractures by about 36%. Adverse drug reactions include nasal irritation, backache, and headache. There is a question about malignancy. A meta-analysis showed a higher incidence of malignancy, but the FDA did not find sufficient evidence to establish a causal relationship, but they urged that the risk and benefits be weighed for each individual patient. Your parathyroid hormone, teriparatide, it's a recombinant human PTH that regulates your bone metabolism, intestinal calcium absorption, and renal tubular calcium and phosphate reabsorption. It typically can reduce vertebral fractures by 65%, non-vertebral fractures by 53%, and we're not really for sure about hip fractures yet. It's contraindicated in hypercalcemia, bone metastases, and disorders that predispose women to bone tumors such as Paget disease. Adverse drug reactions include leg cramps, nausea, orthostatic hypotension. And again, they're not really for sure about the osteosarcoma. It does have a warning not to exceed 2 years of treatment because of this potential risk of osteosarcoma. And it's just important to measure the calcium, PTH, and vitamin D levels before treatment. So treatment with teriparatide should always be followed by an anti-reabsorbent agent such as a bisphosphonates to prevent bone density decline and loss of fracture efficacy. And then you have your rank L inhibitor, which is also known as Prolia. It's a fully human monoclonal antibody that reduces the amount of rank L in the bone microenvironment and reduces the differentiation of precursor cells into mature osteoclasts and decreases the function and survival of activated osteoclasts. It typically reduces vertebral fractures by 68%, hip by 40%, and non-vertebral by 20%. You have your adverse drug reaction of hypocalcemia, cellulitis, skin rash, ONJ, which is pretty rare but can be seen at higher doses, and your atypical femur fractures. And just like the previous medication, you should correct the calcium and vitamin D deficiency before initiating. There are other treatments that we won't talk about today because they're generally not used. Some of them aren't even approved in the US, but I did just include them for completeness sake. Note that there is different doses for prevention and treatment. So if a patient does have osteopenia, you do have the choice of starting at a lower dose. And then you have your treatment doses listed on the slide. This is a summary of your different agents showing their fracture risk reduction of the vertebral, non-vertebral, and hip. So now then, getting into our choices of therapy. So alendronate, risdiplam, zoledronic acid, and your Prolia should generally be considered as initial options for most patients who are candidates for treatment. Your injectable agents can be considered as initial therapy for those who have highest fracture risk, such as your older women who have had multiple vertebral fractures or hip fractures, or for those who have really low T-scores. They also can be considered for those who have upper GI problems and might not be able to tolerate the oral medications, and those who have lower GI problems that might not be able to absorb the oral medications. And then just for those patients who can't remember to take their meds, the IV might be an option. Now, for patients at high risk of spine fracture but not at risk for hip or non-vertebral fractures, then you can use the ibandronate or raloxifene, and you do have raloxifene, the side benefit of reducing breast cancer. And then denosumab is the agent of choice for patients with renal insufficiency, but it's not recommended for dialysis patients or those with stage 5 kidney disease due to the high risk of hypocalcemia. So no pharmacological therapy should be considered indefinite in duration. All non-bisphosphonate medications produce temporary effects that wane upon discontinuation. If these treatments are stopped, benefits rapidly disappear. In contrast, bisphosphonates may allow residual effects even after treatment discontinuation. Therefore, it may be possible to discontinue bisphosphonates and retain residual benefits against fractures at least for several years. So one should consider risk assessment after 3 to 5 years of treatment. And just some extra information for you guys. Alendronate, typically bone turnover markers increased 25 to 30% after discontinuation of 1 year. And then same with risdiplam. Bone turnover markers return to baseline after discontinuation of 1 year. So drug holidays can be considered in patients that are treated for osteoporosis, and as a general guide, for moderate risk osteoporosis, a provider can consider stopping therapy after 5 years of stability or after 3 years of zoledronic acid. For high fracture risk, you can consider after 6 to 10 years of treatment, or just after 6 years for the zoledronic acid. Your teriparatide or relaxafen may be used during a drug holiday as well for your high-risk patients. And then a provider can resume therapy based on the patient's fracture risk, or if the bone density declines substantially, if your BTMs increase, or if a fracture occurs. So we can't forget about monitoring our patients. In untreated patients, the frequency of testing is really going to depend on the results of the initial test. For example, how close the patient is to an intervention threshold and the likelihood of clinically significant bone loss. A bone loss calculator is available, and I would suggest using it. It's pretty good. But on average, you have age-related bone loss, which begins around in the 50s and occurs at a rate of 0.5 to 1%. And then menopause-related bone loss begins 3 to 5 years before the last menstrual period and continues for 3 to 5 years afterward and occurs at the rate of 1 to 2% per year. And then even more shockingly, again, that glucocorticoid has rapid bone loss, 3 to 5% in a year. So that's important to know. And then for those who have borderline low results of BMD, retesting every 3 to 5 years is usually sufficient. Patients who are comfortably above an intervention threshold may not need to go reassessment for 5 or 10 years or ever, really, unless there's some indication. So then in your treated patients, the goal of monitoring is to really identify those who are still having bone loss. So it's recommended to repeat your DEXA every 1 to 2 years until stable. And what stable means is an increasing BMD indicates a satisfactory response to treatment. Now, if your BMD decreases considerably, patients should undergo assessment for non-adherence, secondary osteoporosis, or use of new medications that might cause bone loss. So to determine whether a difference in BMD is real or simply within the inherent variability of the measurement, it's kind of complicated, and testing facilities must calculate something called the least significant change, or the LCS, for relevant measure sites. And again, this is determined by using a facility's regular technologists, patients, and device. Now, changes in BMD are usually small, usually 0.5 to 2% per year. Treatment failure may be defined as a substantial decrease in BMD, or alternatively, the occurrence of a fracture. But even so, it may be that all patients benefit from treatment no matter what, such as even if they lose bone with treatment, they may have lost more without it. Or if they sustained a fracture despite treatment, they may have had a fracture sooner, or they may have had multiple fractures without it. So the AACE does not recommend combo therapy. If estrogen is used for the treatment of menopause or relaxafen for risk reduction of breast cancer, then you can consider adding on therapy in your higher risk patients. And then there has been some data with denosumab and teriparatide achieving a better BMD response, but no fracture data is available, so we can't recommend that combo at this time. Patients should be referred to a clinical endocrinologist if a patient has a normal BMD and still sustains a fracture without any major trauma, recurrent fractures or continued bone loss occurring in a patient receiving therapy without obvious treatable causes of bone loss. when osteoporosis is unexpectedly severe or has unusual features, and then any condition that can complicate the management. And I will take any questions that you guys have.
So Dana, for those of us who aren't osteoporosis experts, at what point in time should we begin routinely monitoring calcium and vitamin D levels in men and women, as we see them for other things, but don't want it to fall between the cracks?
I mean, I think really you should be asking about calcium intake in everyone, and seeing if they're getting the appropriate amounts. I mean, especially like in your women above the age of 50, I would say that's probably the most important time to start asking and making sure they're getting like that 1,200 milligrams per day. And then same for men, once they turn 50, again, making sure they're getting that 1,000 milligrams per day, or they're older than 71, getting that 1,200 milligrams per day.
Thank you.
But I mean, the key is prevention. So, I mean, really adequate calcium intake should be done from the get-go. So. Boy,
the peanut gallery is silent today.
No, I don't mind.
What do you, so what should be our bisphosphonate that we lean towards when we do think that a patient needs therapy?
I would say definitely alendronate or Fosamax.
Okay.
Definitely not Boniva. I mean, Actonel is okay, but the alendronate, it comes in the Fosamax plus D, and so that's really nice.
And so do you steer your providers away from the Reclast and the Zometa, the long-acting infusions?
Typically, yes. I mean, unless it's the patient, like the Reclass has really good data in men, but typically if someone is just like at a moderate risk for osteoporosis fractures, or if their like T-score isn't like super crazy low, then just the orals will be fine.
Okay. Others on the call?
I would say like the most important takeaway is just assessing your patients for osteoporosis, because it's just something that you can miss, especially whenever patients are on steroids. I see a lot of docs just forgetting that because it's easy to slip away from the mind. So just keeping it in the back of your mind.
So if a patient was already on the bisphosphonate for 5 years and completed treatment and then fell back to baseline, would you ever reinitiate them if they were at a younger age?
I mean, maybe. I think it would have to like depend on the patient and like their other risk factors for having a fall, or like if they had any of those secondary causes of osteoporosis. But once you go on a drug holiday, I mean, you can be restarted back on therapy after so many years.
Okay, thank you.
Does that answer your question?
Yeah.
Okay.
Well, thank you very much, Dana, for a wonderful presentation. That was completely encompassing of everything we needed to know. I hope that everybody has a wonderful weekend and relaxes and stays safe. And if you are interested in the link to the recorded webinar from today, please let me know. I'll be happy to share it with you. And once again, thank you, Dr. Leefers, for your time and energy on the presentation.
Oh, you're welcome. Thank